Well, hello and welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tech Answers. Thanks for tuning in. On this program, we address your questions covering the full spectrum of the payment program alphabet, including MU, PQRS, VBM, MIPS, and more. On today's show, we discuss understanding and preparing for the public reputational impact of the MIPS score. Our experts from SA Ignite, of course, is Tom Lee. He's the founder and CEO of SA Ignite. Tom is a serial entrepreneur and leading expert in healthcare value-based programs such as MIPS, MACRA, Meaningful Use, and PQRS. You can contact him directly at tom@SA Ignite. Tom, I'm going to turn the slide presenter for you, and I'll see you back on the Q&A.
Sounds great. Thank you, Carol. Hello, everyone. Hope everyone's had a great month since we last met here. I wanted to actually start out with a little bit of a tangent and talk about some interesting things that have really happened over the last month. And obviously, one of the big areas of discussions around MACRA is the potential delay or shortening of the reporting period for MIPS and for MACRA. And I wanted to share some observations that we're seeing out in the field regarding this. The first is that, and this is really more of a reminder, that when you really look at the first payment year being 2019 as mandated in the legislation, any change in the payment adjustment year would require congressional action that would be really moving against a pretty large majority that we've seen, very bipartisan, to change the payment year. So you can think of 2019 that is one of the things that's most set in stone, that payment adjustments will start working. We'll start operating at that point. Now, one of the things to look at a potential delay of the performance period, okay, which is what we're going to talk about for the rest of the slide here, is that you really got to work backwards from 2019 being the payment adjustment year. And one of the key things that really CMS or anyone has to consider is what are the mechanics of actually running a program that in such a way that by the time you get to 2019, you actually have the quality scores and the performance scores to be able to really start applying payment adjustments. So that kind of sort of relates to the second point, is that if you look at the four different categories of MIPS, one of them kind of stands out with respect to this issue, and that is the quality category for MIPS, which makes up 50% of the score. And essentially, if you really look at the precedence of how PQRS and value-based modifier have been calculated and what's involved in that calculation, and really knowing that MIPS quality is sharing a lot of the same reporting mechanisms, they're going to, CMS is obviously making changes to how the score is calculated, but really a lot of the data aggregation and the crunching of the numbers is really very similar. And right now with PQRS and VBM, there's basically this 2-year lag between performance period and payment adjustment period. Now, if the payment adjustment period remains 2019, then one can basically infer from that that the quality category could be one of the most difficult categories to postpone, because you'd be running up too close to the period of the payment adjustment if you move the performance period too close to the payment adjustment period. And I think that's just sort of a fact that one should really kind of think about and sort of trying to look at the tea leaves and saying where might things go. The other aspect of this, actually before I go next, the other aspect of this is that PQRS measures, which really dominate that MIPS quality category, have been reported on a calendar year basis for 4 or 5 years now, depending on the method that you're talking about. And it would actually require a really different way of thinking and calculating measures if they were to suddenly say, okay, you only have a 90-day window for PQRS reporting now for MIPS. And that, again, could really impact the mechanics of the calculation and create more work for CMS, not less. And that's just another consideration to think about. And so we'll obviously see for sure in the final rule, but these are things, all kind of barriers that CMS would have to work through in order to make any significant change to the quality category performance period. I think on the flip side, for meaningful use, CMS has implemented 90-day periods on many occasions. And so that one could infer from that that could make it more feasible for CMS to do the same for ACI and make that into a 90-day period. And as we'll see in a moment, that's the #1 most requested comment among the 11 of the largest leading advocacy groups on MACRA comments is around making the ACI window shorter for next year. This fourth consideration is kind of an interesting, and really kind of think through it, is that let's say if all 4 categories of MIPS were delayed, then what that would eventually actually do is it would open up a vacuum of time where there'd be a period of time in which MU, PQRS, and VBM have all terminated because of the legislation, macro legislation, and there you'd have this gap in time before all four MIPS categories would turn on, where you'd have a vast majority of Part B clinicians that during that period of time would not be subject to any Medicare value-based performance measurement. And that actually runs counter to CMS's strategic objective of achieving 50% of all payments to be subject to value-based rules, and if not 80%, going forward. So that's sort of another kind of interesting consideration strategically, and sort of what does CMS want to message to the market of how important value-based is. Having a gap in time where most clinicians are not being measured for their value-based performance potentially runs counter to that strategic objective. The other fifth point is almost like by way of, again, by a reminder, is that MIPS is a competitive program. There's effectively a limited number of MIPS points to be distributed among competitive peers around the country. So any kind of delay that happens, every eligible clinician would likely gain the same advantage as far as it'd be delayed for everyone. So that everyone would have more time to prepare. And that's very important, because this program is where every point counts, as we've gone through many times before on our past webinars. So every point you can directly translate it into dollars. So if everyone's getting the same advantage, how much does that really help me if I'm trying to be one of the winners and not one of the losers? And finally, this is just a general observation we have in talking with many organizations, and there's a lot of activity now. Very few organizations are slowing their preparations for MIPS, despite the fact that there might be a delay of one or more components. The fact is that MIPS is too complicated and it's too impactful. 3,800 comments on 962 pages. Few organizations are willing to say that an extra X number of months is going to buy them that much of an advantage if they don't really seriously consider planning, at least planning for it now. Okay, so this might come out in the Q&A as well, but this is just, I just want to share this. I know this has been a hot topic, certainly in the media, and just some things to keep in mind. Okay, now the next piece here, before we get really into the public reputational piece, which I'm very excited to share with you guys. This is sort of a whole other aspect of MIPS that has not gotten as much attention, but is actually potentially even more impactful than direct financial reimbursement. Before we get to that, I just wanted to share with you all, I've written an article in one of the major publications here. You can see the link below. You'll get the slides, where basically what our team did is we did a deep analysis of the macro comments that were submitted by these 11 leading organizations. And if you look at this list, basically represents probably more than 95% of the providers in the country, one shape or manner. And what we did is we sifted through all those thousands of pages, and we basically were able to put into different buckets the types of comments and came up with the top 9 most popular comments across all of these organizations and what they submitted to macro, to comment on macro. At the top of the heap is what I said before, is shortening the ACI performance period. 10 out of these 11 organizations are arguing for that, probably due to the fact that they realize it's probably one of the more feasible changes that CMS could implement. Many others here, there's 3 others I think are quite notable. The third most popular one is reducing the quality data completeness threshold. So this is the proposal that for quality reporting, for the vast majority of reporting methods, you have to report at least 90% of all of your patients, not just Medicare patients, all of your patients, in order to meet the minimum reporting requirement. And a lot of concern around 90% is really hard to achieve. Right now it's 50%. And it'll be interesting to see how CMS strikes that balance. And I think there's good arguments for both sides. Look for a potential compromise on this one, between 50 and 90, potentially. Delayed program start, we saw that. I think what's notable about delayed program start is it's not number 1. It was sort of interesting. I was expecting that to be number 1, but it turned out that it's still in the top 9, but there's others that are ahead of it. I think that's also a reflection of the fact of how realistic some of these organizations feel delaying the program start would actually be something where they want to put a lot of their advocacy effort behind or not. And lastly, another hot topic has been really suggestions to somehow give the Track 1 ACOs under the Shared Savings Program either immediate benefit as an advanced APM, which gives them a MIPS exemption as well as a 5% annual bonus, or to have some other kind of glide path where these track 1 ACOs that are 95% of all ACOs are track 1 to be able to become an advanced APM a lot sooner or a lot easier, but in a more straightforward fashion. All right, so this might generate more Q&A and whatnot, but I definitely want to share this with you all. And again, you can read more about this at the link below. Okay, now onto the topic at hand. Today we're going to talk about an interesting other side of MIPS, and also we're going to talk about this generally, not just in MIPS, but also across a number of value-based programs, which is the fact that MIPS and many other programs are reporting and committed to report even more quality measures and scores through public channels, and that information is increasingly being re-provisioned by third parties, which we'll show some examples of, who really understand how to market to consumers, to really try to add value to the consumer ecosystem in terms of how consumers make choices with the healthcare spend that they're increasingly taking out of their own pockets. How do they choose providers? How do they understand who's a good provider or who's a good fit for them? And we're going to really split this discussion up into, first, I want to tell you just for MIPS, what is actually in the legislation and in the proposed rule that specifically states the nature of the public reporting of the MIPS score, and what does that entail? And then we're going to move to what is, putting MIPS as just one bucket of many buckets of public reporting. What does the overall landscape of clinician quality ratings kind of look like right now from a 10,000-foot level? What can we learn from that? And we're actually going to look very specifically at some programs, like most recently the Hospital Compare Star Rating Program, which got a lot of press a couple weeks ago. First time every hospital in your region it has a rating out of 5 stars out of Medicare. What's been the reaction to that? It's really interesting, and kind of think about when MIPS gets to that point, or any other value-based program gets to that point, what are the types of things that can play out in the market? And then lastly, of course, not least, is what are just some simple things that we're hearing and seeing about how provider organizations are thinking about this and are preparing for this additional increase in the amount of publicly available data out there from payer sources regarding their providers. All right. Okay, so let's first start with just MIPS. And so to really be very concrete, I simply took extracts from the MIPS macro legislation. And what's really underneath here, there's not a lot of detail, obviously. It's just the legislation that went through Congress. But there's specific points here. First is that the CMS Physician Compare Internet website will be the distribution point, as it has been for PQRS measures. That will also be true for MIPS. And in that data feed, for that data source, the data shall include the composite score for every MIPS eligible professional, and that also includes groups that decide to report MIPS as a group, and also the performance of each such entity on a named basis, also with respect to each of the 4 performance categories. So you're going to have Dr. Smith or Group A with a score of 78, and 23 of it's from ACI, and 45 of it is from quality, and so on and so forth. That will all be, that's mandated to be published out there on a named basis. In addition, CMS may decide to include the performance actually of each individual measure. And so if you think about some of the quality scoring that we talked about in previous webinars around MIPS, so that would mean, okay, I could potentially look at the individual point contribution of the immunization measure within quality and be able to say this provider got X out of 10 points on that particular measure. So that's an optional piece. Given that with PQRS, more and more status quo is that they are getting to that level of granularity, reasonable to conclude from that CMS is certainly looking very hard at doing that too, at the measure level, not just at the score level. Okay, so that's the legislation. Now the proposed rule goes a little bit further in detail. I know there's a little bit of an eye chart, so I'll try to talk through it here. The proposed rule reinforces obviously what's in the legislation, but it also adds some other interesting things. So for example, the proposal is to not only report the individual scores of different providers and groups, but to also publish the aggregate numbers. So for example, nationally, what is the maximum score and what is the minimum score? what's the range of performance that clinicians have actually fallen in within a given performance year? And also on physician compare. The other part that it further reinforces, and this is going to be important for our subsequent discussion here, is that right now physician compare also provides PQRS measures in a structured format that can be downloaded by any third party, health grade, so on and so forth. We'll see a list later, for them to use that data really however they want. It's totally free of charge. And what is mentioned in the proposed rule is to basically do exactly the same thing with MIPS scores, is to provide it in a what they call a downloadable database. And there's already precedence for this, where a third party could take that and use it however they want for the benefit, presumably for the benefit of consumers, hopefully for the benefit of consumers, or providers who want to improve. And you can see there's reference to kind of current policy, so there's already precedence for this already, so there's a kind of a strong gravitational pull just to keep it consistent across MIPS, make all the measures available, so on and so forth. This is also interesting too. It's also including making all the measures available that are submitted through all the different quality submission mechanisms across all the categories. And so one could eventually see measures that are reported using the GPro web interface method or PQRS registry of individual providers, or all the panoply of methods, have all of that become more and more real. I think what's interesting here is that over the last couple of years, CMS has been a little bit gun shy in terms of releasing all of the data across all methods because they found some statistical inconsistencies in the data. One thing to kind of look at is in terms of as the volume of historical data starts to build up under PQRS and all these different methods, it gives CMS more wherewithal and ability to pass some statistical tests and actually get many more measures out there in the public domain than you see right now. Okay, so it's just something to kind of track. Okay, so that's really Mr. Mackey. So really MIPS is taking the same direction, okay? And now I want to go back to the 10,000 foot view. What's really going on overall in this landscape of clinician quality ratings? And it's going to go very broad here, and I want to kind of do it this way. So first is sort of by way of an overview. So let's think about all the different channels that many of you all have seen physician ratings when you go looking for a provider for yourself or your family. One is obviously through a payer like CMS, and there are also some private payers that also make some provider quality data available as well, but CMS is by far the dominant one in terms of doing that. There's also third-party clinician rating websites, which we'll look at in some detail in a moment. And interestingly, there's even some large health systems that have made it a priority to publish their own clinician ratings for better or for worse. And it's actually the good, bad, and the ugly. In almost all the cases that at least I've been exposed to, it's not just publishing the measures that look good or the clinicians that look good. Self-publishing. Why are they doing that? What benefit to their organization do they feel they get by doing that? Interesting questions. I won't have all the answers, but the question's constantly being asked more and more now. And then who's consuming these ratings? Obviously, there's the consumers themselves or the caregivers that are looking for the best hospital for their elderly parent, for example. That's consumer. When you really kind of look at this space, what's really interesting is that there's another set of audience members, which are actually other clinicians. And those clinicians, they realize that the recommendations or the referrals that they give to their patients can ultimately come back to haunt them or to benefit them. And we're actually seeing interesting usage statistics around clinicians looking up other clinicians through many of the very same data sources that we all non-clinicians use. So that's another thing to kind of keep in mind in terms of what could be impacted as this starts to really blossom. All right, so let's first focus on kind of what CMS is doing. This basically is just showing graphically what I've already said, is that there's there's been an inevitable trend to generate more and more publicly reported measures out there in the public domain from CMS. It's been continuing the last couple of years, and MIPS and macros can take it up to another level. You have a third-party, a structured file that's available to third parties. We've kind of covered that. And there's some more references down here if you kind of want to look more in detail at the history of CMS doing this, but it's pretty clear that their proposal to do this in MIPS is very credible. And then really as I mentioned, one of the areas of CMS ratings that's gotten a lot of press just this month is around the hospital star ratings. And when you look at that, there are some things that portends kind of the future of where physician compare website could go with respect to MIPS. And I want to point out a couple of things here. Again, apologies for this being a little bit of an eye chart. So this is actually the hospital compare website, where just a week or two ago, I looked up in the Chicago area here, within 5 miles of where our office is, there's 10 hospitals that have star ratings. And I de-identified the hospitals, but you could easily go and look it up yourself if you're really, really curious. A couple of things of note here. First thing is it really does boil down every hospital to a single star rating. So you have the first two that came up here as a 4-star and a 1-star. And when you look in the lower right-hand corner, there is a meaningful distribution of stars here. It's not like everyone's getting 3 and 4 stars. There are people who are really in the basement here, and people who are higher, and nationally there's a very small proportion that are up here in the 5 stars. That's kind of interesting, that these star ratings are turning out such that there's actually a meaningful distribution. Not everyone is bunched at the top or bunched at the bottom or bunched in the middle. This is only within a 5-mile radius. Chicago is a very competitive market. These hospitals all know each other, and I think one can surmise that Hospital B is not very happy about where this came out. Nationally, there's probably a lot of other hospitals that are not happy about this, and we'll see kind of some media pieces about that in a moment. But if you look nationally, this is published by CMS, of the 4,598 hospitals that did get a star rating, that's out of a total base of about 5,500. Some hospitals don't get rated because they didn't submit enough data, or they had other confounding variables. You can see 2.2% got 5 stars, and the distribution kind of goes as a classic bell curve in the way that you would want it to look. You know, if you want to get some real good differentiation between different levels. So that's really interesting. As a result of this, there's been a lot of discussion and interest in this. Not so much that people think that suddenly all consumers are going to know about Hospital Compare and just using it all the time and millions of hits per month or anything like that, but it's really, some of it is that, and some of it is seeing it kind of right in front of you on the web, but a lot more of it is around the realization that third parties now have access to all those star ratings, and they can fold it into their consumer information offerings however they want. And it's unpredictable. The unpredictable nature of what third parties could do with this information is a lot of what we're seeing is driving a lot of the concern. Now, before I get to kind of some of the pain points concern around it, some other facts about Hospital Compare, just so you can kind of get a flavor for it. What CMS previously had on Hospital Compare was simply measure level reporting across the inpatient quality reporting system and the outpatient quality reporting system, almost their version of PQRS, or hospital's version of PQRS. Very familiar to many of you who are in health systems. And of the 115 measures that you can currently get data on from Hospital Compare, it's been true for a couple of years, CMS looked at that and said, consumers can't understand 115 measures. Let's boil it down to a single star rating. So for that, they developed an algorithm, and they selected 64 of the 115 and used just those 64. They ran it through a filter where only they deemed these 64 the ones that are best usable to create a star rating. The other part of that is that these ratings are based on a performance period that ended 15 months prior. So really, in terms of the public seeing these star ratings, it's for a period that happened long ago. And that certainly creates some problems from a hospital point of view or provider point of view in terms of now consumers are seeing how you did 15 months ago. It doesn't say anything about how you're doing right now or how you could do next year. So that lag, again, is what we've also seen. PQRS, VBM, and also MIPS will have the same issue, is there's this lag between the performance period and when data is available to the stakeholders. And lastly, the hospitals were provided a preview report of their star rating a few months prior to August. There were also a lot of questions and need for knowledge around how the star ratings were derived, things like that. There was a big push by AHA and others to really postpone, sometimes even indefinitely, the publishing of those star ratings until some of those issues and questions could be answered. But nevertheless, CMS published it out in August, and one of the big reasons why that is because there's a lot of consumer advocacy groups. They don't necessarily understand the nuances of star measurement or quality measurement. They're pushing to have this revealed out to consumers. And so at the end of the day, one could potentially say that their voice was pretty large from the consumer side, and CMS really, really had to go forward with it, despite the imperfections. So when we think about these things, if you look at MIPS, it's very similar in these three attributes. And I think it'll be really interesting to see as we really get into the meat of the program and people really start to realize that the reputational side is potentially way bigger impact than a single years of reimbursement, because once a provider's reputation falls to the floor and the glass shatters, it's a lot easier to put, it's a lot harder to put the pieces back there. It takes longer to reverse that impression out and in the consumer's mind. Any marketing expert would tell you the same, or if you are one, then you'll know what I'm talking about. Versus with the reimbursement side of MIPS, although it's very impactful, it is very possible to bounce right back the next year, because next year you have a clean slate and consumers don't see the reimbursement that you're getting. They can't draw any conclusions. It's all private between CMS and the provider organization in terms of the actual dollars. Now everyone will see the MIPS score, but it's the idea of the bouncing ball versus the glass vase. And this has got a lot of marketing departments at health systems even really starting to be concerned about this, because again, people necessarily see people going to hospital and compare all the time right now, but marketing, people understand healthcare marketing, spending millions to advertise why their services are better than the folks across town. They're very concerned when their hospital gets only a 2-star rating and the other one across the street gets a 4-star rating. So it will be really interesting to see how this plays out, and MIPS is going to be another sandbox in which the public reputational side of things is going to play out. And we're all going to learn a lot from that. And here's some of what we'll also see is when MIPS comes out, the scores come out, you're going to probably see something like this as well. A lot of the public reactions, certainly from hospitals, being quite negative. But interestingly, if you simply Google hospital compare star ratings and you look to the news on Google, you're going to see a number of hospitals really touting their star rating already and getting into the local press and saying, we got a 5-star rating and we're one of only 2.2% of hospitals that got this. So how will other hospitals react to that? It'll be interesting to see, because some are clearly shouting it from the rooftops. And with MIPS comes along, I think one can reasonably expect that it will also be the case that the high performers are going to make a big deal out of it. And plus, they're going to be getting more reimbursement at the same time. So that's a real potential kind of double consideration for these scores going out there publicly. All right, so I want to switch gears now. Let's kind of look at sort of that broader landscape of what are these third parties out there, these black boxes that they can do whatever they want with these measures and these scores from CMS on an annual basis. So probably one of the granddaddy of them all is healthgrades.com. And I recently heard a speech by some members of their team, and they're continuing to drive about 30 million visitors per month to their website. They actually currently do use some parts of the CMS data set, but as we all know, there's a lot more coming, and at even a finer level of granularity. They're going to get a score out of 100 that's stamped with approval by government for each provider or MIPS group. But if you look at their webpage right now, clearly they've bought into the star rating system. And what's interesting is that they also have a model by which they make money through advertising. And when I kind of looked at this example on Healthgrades, it's kind of interesting is that this was for practice X, and they got a certain star rating. But they have ads that pop up for the competing organization, which I'll call Hospital Z, which somehow is matching on other things about what the user is searching for in a provider. And it shows their star ratings on Healthgrades. It shows the name of the hospital, which I've de-identified. What's interesting is it also shows their one doctor that's not doing so well. 2 stars. It actually automatically pops up in the ad. So they're advertising their highly rated ones, but the ad is either, inadvertently also showing their lowest rated one, whereas the organization that's now being searched on and looked at is has a higher star rating than this provider. So again, in terms of how consumers react to this, remains to be seen. Are there stats on that? This, how much does this change a consumer's thought process and decision-making process? But this shows you how new this is, because this has not been optimized. They should not be showing Dr. D in the ad when this provider Dr. A has a higher rating at a competing organization, okay? So this is marketing 101. Again, another reason why a lot of health systems marketing departments are really starting to get on top of this. The other notable fact is very low sample sizes. Most of these star ratings on sites like this are based on patient reviews, and those are quite tricky, as I'm sure a number of you all know. But what's notable is that the sample sizes are very, very low. So if I'm a product manager at Healthgrades, and right now I'm seeing sample responses of only 2 surveys, and I suddenly have a new data source from CMS, as imperfect as it may be, and it represents hundreds of thousands of providers. For each provider, I'm getting at least 20 patients into the measurement denominator of every single measure. That looks very attractive to me as an alternative to what I have right now, or to augment what I have right now. And that's exactly what these product managers are thinking of. We know a number of them, and there's no doubt that they are eagerly awaiting, in particular, the MIPS and the macro data in order to leverage that and capture more market share. Some of the real traditional big players in this, Consumer Reports, choosing the right doctor for you. They have their own ratings. More and more, as more and more of the healthcare dollar is determined by the patient, and they're paying for it from themselves. It's a general trend that is continuing to make its way out. And you have a lot of startup companies too in this. So this is an interesting company, Amino.com, founded by an ex-vice president of Zillow, the famous online real estate site. They raised about $19 million from some very big brand name venture capitalists to basically aggregate a lot of these data sources, including CMS data sources. They are very much in the CMS data area. They have 188 million patients worth of data, and what they're doing is they're basically doing Match.com between patients and providers. And so they have a scoring mechanism that matches providers, and certainly quality is definitely one of them for what a provider is actually looking for. This is all, by the way, these are all make-believe providers, so there's nothing private here. But the point, and there's a mobile version, all that, there's all these other players that are coming out of Silicon Valley and others that are going to have access to the very same data. Now, what this is reminiscent for maybe many of us who were outside of healthcare for much of our careers is you look at the weather information. So Weather Channel, WeatherBug, all of the weather properties out there in the media is a multi-billion-dollar industry. It is a little-known fact that they all get their data from the same source, which is the government's National Weather Service. They all use the same source of data. The National Weather Service did exactly what CMS is doing right now as far as providing data for free and letting the marketplace leverage that for consumers. And so I think just a word of caution to those who may be skeptical about, hey, patients don't really believe this stuff. They're just going to continue to get, do what their family members are doing or whatnot. For now, probably true, because it's hard to change behavior. But you got a lot of very innovative, well-funded information companies that don't believe that. And pretty soon there will be a weather channel for providers, or there will be a weather bug for providers. This is my personal opinion. Again, this is just my personal opinion, not even our company's opinion, that it's just a matter of when, not if. Okay, and the question is where do you want to place your bet? What do marketing departments want to do about this? It's something I'm quite passionate about, is that providers don't necessarily give it enough weight right now, but increasingly they're going to need to in order to be competitive. And in fact, some health systems are very forward-thinking on this. So Cleveland Clinic, Beth Israel, they've been publishing their ratings and their scores out there for a number of years. And and also Dr. Jha from Harvard just this year publishes that he's advocating all healthcare providers should publish their own ratings. And there's a lot of reasons behind that, and one of it is transparency. It's a relationship with their customer, which is the patient, and it's another way of engaging patients. But in order to do that, you really got to publish your weaknesses too, and that's exactly what Beth Israel and Harvard Medical School did. As you can see, they're actually publishing measures. These are actually inverted measures, so a higher score is worse, where they are way off where they want to be as an organization, and they're even worse than the benchmark that they're comparing against. But it's out there, it's publicly available. Okay, so that's an interesting strategic question for health systems is, how far ahead you want to get at this? What kind of price might you pay in the short term? But, how do you want to play this reputational game is a whole separate discussion and impact of things like MIPS that we're finding people are thinking about it differently than they think about the direct reimbursement impact. And as you go through that, looking at both sides of reputation and reimbursement optimization, you're going to find there's a number of decisions that you have to make where those two competing forces are at odds with each other. And that's where there's a lot of really interesting activity, going on about how to thread that needle. That I look forward to having future webinars about that too. Here are some stats. Let's look at some numbers. So if you look even as far back as 2014, in JAMA, Journal of the American Medical Association, simple question was asked. First of all, how many of you consumers are even aware that there's a physician, that there are rating sites for physicians? 65%. What percent of you have actually used a rating site at least once? More than a third. And of those who used it, how useful did you find that site? 96% said very useful or at least somewhat useful. This is early days. This is 2 years ago. This is before a number of the companies are doing what they're doing now that I showed you in previous slides. Here's another interesting result from another survey where they asked, okay, well, at what stage of the decision-making process about choosing a provider are you using these websites? 62% is that their first step in finding a new doctor is to go on the web and look at those sites. 19% on evaluating an existing doctor, whether they should stay with a provider, and another 19% is to validate who they think they want to choose. These are pretty significant, particularly on the first step of looking for a doctor, and it's kind of logical because we live in an internet age. And this is increasingly of concern in terms of what we hear out there. And it's not to be lost track of relative to the short-term reimbursement impacts of these programs. All right, lastly, and I think we're doing really well on time, so we'll have a lot of Q&A time. We'll try to get to as many of your questions as possible. Last year is just a simple couple bullet points on how provider organizations are thinking about or preparing for this. And what we see is we do see an increase of activity here. It's not as fast as it is on the reimbursement optimization side around MIPS and APMs, but nevertheless it's growing. And things like hospital compare, star ratings come out, further accelerate the conversation. So the first thing is that we're seeing organizations, they're starting to really realize that there's an importance of trying to have some kind of surveillance of what people are saying about their providers, and also what these ratings are going to really look like out there, like how are they being presented? How is the MIPS score going to be presented? Or where are these star ratings appearing? Where consumers find information are those things actually appearing? One interesting example of this is there's a large health system in Texas that's done a really amazing thing. Is they invested in one dedicated room where the room is all four walls are covered with large display LCD screens. And they have a team of millennials in there, not to stereotype, but millennials, that are very versed in social media, and they simply look at the walls, displayed on the walls, essentially for the entire day, and they look at what's being Twittered, Facebook, so on and so forth, health graded about their providers, and they have an action plan to basically get ahead of it. All right, now this is really very, very kind of innovative out there, but it's sort of, I think it's a sign of things to come of how important this is, because certainly commercial enterprises that have that type of exposure and that type of information on the internet have for many years been taking measures like that, and responding, how do I optimize my Google ratings? How do I not have this appear but have this other thing appear? It's really starting to happen now, and there's even a number of companies that are now starting to provide that to health systems. Another one that we see a lot of is is a reference back to what I described before about how sometimes the reimbursement optimization could be at odds with reputational optimization. And the one specific example that seems to come up a lot is around whether you should report providers individually or as a group based on TIN for MIPS, PQRS, or any of these other programs where you can make the choice. And there's first as we've talked about in previous webinars, there's first the reimbursement optimization question, where clearly you can usually see a noticeable difference, if not a big difference, between these two choices. Because individual provider, for example, you can choose measures for each individual provider versus a group. Everyone is being lumped together on a single bandwagon, and that has a reimbursement impact in terms of how much reimbursement you can possibly get. But this also plays out in the reputational realm. So if I'm a 100 provider multi-specialty group and I have some really strong cardiologists, many of them are unlikely to be happy if their 5-star ratings are being hidden within the group and the whole group is getting 3 stars. They are lobbying for that, hey, we can be an asset to the organization. Please report everyone individually, including us, so our 5-star rating as a great cardiologist can help bring in more business and also can further my career as a provider. Because, of course, it would help them as a provider. Their reputation is something that is beyond any organization that they happen to be part of at that moment. But then by doing that, other providers within that same multi-specialty group may not be ready to have their individual scores revealed out in that manner. And so in addition to the potential reimbursement downside of that, there could also be real reputational concerns of those other providers. So these are things, whereas for reputation, for reimbursement optimization, it could be that sticking as a group for reimbursement purposes is exactly what you should do. But reputationally, individual provider might be what you really want to do. And so how do you, again, thread that needle and balance it as reputational becomes a bigger consideration, particularly in the C-suite and in the marketing departments that are spending millions on trying to attract patients with their quality? The stakes have raised up even higher on this type of decision. And there's a number of other these type of trade-offs that one's got to think about when looking at short-term reimbursement versus reputation. At the end of the day, you're trying to optimize what you think is the overall sum of the parts to be the best for the organization. Another, again, we've talked about this previously in terms of MIPS readiness, is we're seeing this as well on the reputational side, is everyone really wants to know, can I find out what my STAR rating might be before it's actually already out there 15 months after the performance year is over? And again, we're seeing definitely a lot of pull for that. Not necessarily a lot of solutions out there to do it, across all these different programs, but there definitely the desire to try to monitor where you think your STAR rating is going to be or where you think your MIPS score is going to be. And certainly in MIPS, it's all been about really these two categories are sort of the bigger ones for year one. Okay, and finally, and I've said this over and over again, is that, yeah, there are sort of new types of people coming to the value-based discussion within organizations now. And marketing departments, sort of started with finance, where they suddenly realized, hey, this isn't just a couple of percent of our revenue that's at stake, this is 10%. And what we're kind of seeing now is the marketing departments, as they learn more about, they're asking all kinds of questions about this data, because they read the New York Times and Newsweek, and just like everyone else, and they know these STAR ratings are out there now. So they're asking more questions, they're taking notice, and probably that next level is, okay, well, what can we do about this? Is going to be that next level. And I think it'll be really interesting over the next 12 months in particular, as MIPS starts to become more and more pervasive, and certainly also some APMs also publish data metrics publicly as well. Is how does that all play out in the public domain? Is something I'm very eagerly awaiting, to kind of see how that plays out, and we'll certainly be part of that conversation as well, and trying to really learn and bring back, certainly to this forum at least, some of the learnings that we get. So, Carol, that's my last slide. I'll hand it back to you, and we can take some questions. Oh, actually, I'm sorry. One last thing, by the way, just a real quick note. Last webinar, we talked about this free MIPS ACI score calculator, where we can basically give you a tool to estimate your ACI score based on your MU measures. That is now available, and you can go to our website in this manner. I'll keep the slide up for a moment. It is available now, and please let us know if you have any feedback or questions. We'd love to hear from you. Carol?
Yeah, definitely go on your website and check that out. It's very, I've downloaded it at various versions along the way, and it can help you a lot. So, all right, so I'm going to take some of the questions that we got from registrations and then some of the questions from the live audience. To remind everybody that I'll get this recording edited and uploaded to YouTube and get it out to you via email along with the slide deck. All right, so first and foremost, what happens if a provider does not participate in MIPS or APM? How does this affect their public reputation?
That's a great question. So, for example, within MIPS, if you decide to not report for required categories such as quality, which makes 50% of the score, then and you're required to meet the minimum reporting requirements, such as meeting the data completeness threshold, picking the 6 measures, whatever the method you're using, you'll get a 0 out of 50. So that will have a very big impact by not participating when you're obligated to. If you're a MIPS eligible and you're not in one of the advanced APMs, you're obligated to report quality in almost all cases. You'll just get 0 out of 50, and that will hurt reimbursement and reputation. The question was also expand to also other parts of MACRA. So if you are in certain, and we talked about this last month, if you are in certain APMs where you still have to do a constrained version of MIPS, then the same, what I just said also applies in those cases where whatever categories you're still obligated to report on. And then finally, as I mentioned, is that many of the APMs also have public reporting. Obviously, the shared savings program for ACOs, all of the quality measure rates, as well as quality scores are all publicly available. They are available for download by third parties. And it'll be interesting to see what those third parties may want to do with those things beyond the CMS's own website. So that's kind of a broad answer to a broad question.
All right. And do you happen to know or have a sense of when these physician scores will be made public after they're reported?
Yeah. So you're going to see about the same type of lag that we're seeing now, which is really that probably around 15 months or so lag from the end of the performance period to when the scores and the measure values are published by CMS.
So 15 months. That's so funny. A lot can happen in a practice in 15 months. Yeah,
absolutely. Yeah. I mean, some of our some of our organizations we talk to have mentioned that it's kind of like you're always 2 years behind, right? Because your performance period, you wait more than a year to find out how you did, and then but you still might need another year to actually get better at it. By then, 2 years have already passed between your previous performance period and when you can reasonably expect to get improved performance. So, again, there's ways to kind of try to get ahead of that, predictive analytics and other things, but it seems to be a design pattern that's pretty consistent with a lot of these value-based programs, is that they simply need time to even calculate where your performance is, and usually that's measured in months and not days for them to do that.
It's just the way that works. Do you know will CMS provide the public with guidance on how to interpret the data?
Awesome point. Awesome question. And Carol, if I can invite you to kind of scroll back to the hospital compare website that I showed with like hospital A and hospital B. I think, yes, there's a lot of user guide type things that CMS has provided and can provide about, hey, here's some caveats around this information, consumer. Don't take it for, don't go beyond what you might want to get from it, because there's all these caveats around it.
Right.
Can you go back another slide? I want to go to the screenshot of the web page. Yeah, just go one more. I just want to see the web page.
It's one more back. Hold on.
Yeah, I think it's one more back.
There.
Another one.
One more.
Yeah, the one with the one more page. Go back to the hospital compare one. Thank you very much. So what Carol's doing that. So the reality is that when you see this website, and if I'm a consumer, like how often, when you go and you as a consumer website, how often do you look at the FAQs and the user guide on how to use the website? Or do you just start using it? And you just start drawing conclusions from what you see? And that's probably a reasonable analogy to take from outside healthcare into this space, is that whatever a consumer sees there is the guidance that they're going to use. And so then there's a lot of burden on CMS or any of these third parties to make it such that any guidance or any kind of caveats around the data have to be made front and center with the consumer in a very smart, efficient way. And that's very hard to do because this data is complicated. Where do you step on the gas pedal? Where do you step on the brake as far as prioritizing information? And it's just something that people are wrestling with. And so there's a lot of uncertainty about how much of a grain of salt can you really have consumers take when they see these ratings? I think that remains to be seen.
Right. Do provider scores only reflect quantitative structured data, or is there any qualitative data that is reflected in the score?
Yeah, great question. So it varies by program. If you look at, for example, the hospital compare star rating system, they have the IQR measures. I believe they also have CAPS measures in there, which are patient experience measures. I could be wrong on that. I have to look back again, but MIPS certainly does have that piece in, as do a number of the other rating programs. And CAPS measures, does obviously have some qualitative feedback in terms of, how's the environment of the practice, things like that, that can translate into numbers, but still kind of qualitative impressions. That's probably mainly where you'd see it, is around measures like that. And there's some other things which are more of the yes/no measures that then can be reflected in the quality score as to whether an organization has certain things in place. And to the extent that CMS thinks that's correlated with quality, there are places where those type of measures are also folded into the score.
Okay. Do you know, will patient satisfaction surveys be a requirement?
Yeah, that's another great question. I partially answered it there. For MIPS specifically.
Yeah, you did.
Yeah, so for MIPS specifically, great. So the proposed rule says that CAPS for MIPS, formerly known as CAPS for PQRS, is going to be optional. You can earn bonus points for it, but the proposed rule says it's optional. So depending on whether a practice takes that option or not and gets those bonus points and gets rated, then CAPS may or may not be part of their MIPS score.
All right, and you also talked about this group versus individual, but I think to review it one more time, if we report as a group, could we hide in parentheses our poor performers in the group score?
Yeah, it's a great point to reinforce.
Yeah.
Is that in effect, yes, you can quote unquote hide. Now there is some nuances around that depending on what reporting method you use for quality. Some reporting methods that it's really hard to hide, particularly if you have to report 90% of your patients, then unless you have 10% of your patients that are the ones that you want to hide, and by the way, you may or may not be able to cherry pick that way anymore, depending on what comes out in the final rule. So, but then there's other methods where it's easier to kind of get the bandwagon effect, and others are sort of on for the ride. So an example is if you report using GPro EHR Direct, using a QRDA file that we've talked about in the past before, and you have some providers that are under the same tin and they're just charting on paper, then those providers are just going to benefit from the ones who report electronically. Okay, but that statement that I just said is not true for a number of the other methods. It depends on what method in terms of whether or not you have the opportunity to quote unquote hide the bad ones within the group. You have to look at it on a method by method basis.
Right. Do you happen to know will the ratings be sort of a star rating that CMS uses for other programs?
Great question. So with MIPS, I think there's a reason why CMS picked it to be out of 100 points, because consumers understand that without even having to have a star rating system. Think about how we look for movies or hotels or things like that. Now, what'll be interesting is that the reason why star rating, one reason why they chose a 5-star rating, why not a 50-star rating system? There's a lot of psychological studies around why 5 stars is sort of an optimal point, because 3 stars is too few, 10 is probably too many. What they did with Hospital Compare, which I thought to be very interesting, is that they used an entirely different algorithm this time to group hospitals into different star levels. And it's not as straightforward as you think. You have to run an algorithm for like 200 hours on a high-powered computing machine that it statistically will somehow magically form 5 groups of hospitals and put them 1 through 5 stars. So with MIPS, it'll be interesting is that CMS could go beyond. There's nothing preventing them from going beyond and layering a star rating system on top of MIPS. My guess is initially they're just going to say this is how many you have out of 100. But if they wanted to do kind of that tiering, they could. Because they could basically use a very similar way of doing they've done for the Hospital Compare side and come up with a MIPS star rating. They could do that. Although I wouldn't necessarily expect that out of the gate, because they already have a scale out of 100 points that people understand.
Right. And, it's like a typical, from just growing up in, going to school here, 100 is an A, is an A. And
yeah,
people
exactly.
totally get, and they will make that, I'm sure, that assumption that, well, if it's below 90, it's a B or B plus or. Is there going to be a requirement to report as a group if you have more than 100 EPs in your TIN like it is with PQRS?
Yeah, that's a really good question. What the questioner is referring to is that under historically under GPro reporting for PQRS, many years ago, in fact, that if you were 100 providers or more, the only way you could report was using GPro. Okay, GPro web interface specifically. That has actually since gone away. Even the last couple of years, if you're a GPro, really certainly of any size at 25 providers or more, you have the full panoply of methods available to you, and you can choose any one of them. The one requirement which I mentioned, I'll allude to, which is the proposed rule is saying will go away, is for organizations that are doing GPRO reporting for PQRS. Right now, CAPS is mandatory. Okay, they're doing the CAPS reporting is mandatory, but as I mentioned, under MIPS, it's proposed to be optional. You will get bonus points, but it would be optional to do CAPS, regardless of the size of your organization under MIPS.
Okay. I'm going to take a couple more questions before we wrap up here. If you are a provider participating in an ACO aligning providers for MIPS reporting, and as a provider we report separately, we've been told that CMS will use the higher score. Is this accurate? I think I read the question correctly.
Yeah, there's two. I think I know what the questioner is saying, but let me first convey one fact, which actually refers back to our last webinar in July, is that currently the proposed rule says that for the Track 1 shared savings ACOs, that they will be subject to a constrained version of MIPS, where basically what that means is that they don't have to double report for quality, for example. But what it will mean will be all of their providers will be rated for MIPS based on their quality category score. So it's the very same, there'll be a single quality submission, but it'll be rated against two different programs at the same time, one for MIPS and one for ACO. So that's the case where there's just a single submission of data, and they have to use the ACO GPRO web interface method, but it will be rated under two different programs with thereby two different reimbursement impacts that may or may not be going in the same direction. Okay. What I think the questioner is referring to is cases where, whether it's an ACO or another reporting entity, where they have reported quality, let's say, twice for the same provider or the same PIN. And it is true that over the last couple of years, CMS has had a policy, whether it's written or not, I'd have to go back and check, that if they get quality measures submitted through two different mechanisms for the same provider, they will use the data that's more favorable to the provider. Okay? But I think that's a separate question. That's a more kind of generic answer to a more generic question that does pop up. Whereas if we're talking about just ACOs in particular, Track 1 ACOs, they only have to submit the data once, but it'll be rated twice in two different ways. Yeah.
Got it. All right. Take one last question, because obviously it's one that's I'm sure a lot of providers think about, is exactly how these scores will affect the physician's income.
Yeah, that is a very profound question. So first of all, we know for programs like MIPS, the score does have a direct impact on the payments from CMS. Now, in terms of how a provider organization may or may not tie that to a physician's bonus or salary is up to the provider organization. Okay. I think the more interesting kind of newer part of that question is ultimately what impact on the business model and revenue stream of an entire health organization could be impacted by reputational scores being out there. And that has everything to do with a marketing question, right? Is how much is it costing you in revenue globally if your providers only have 3 stars versus have 4 stars, that the guy down the street has 4 stars and you only have 3? Okay, and that's, it's obviously it's much more complicated to try to project that, but it's also something where once the market decides how much weight it wants to put on 3-star versus 4-star, and they start voting with their dollar, with their pocketbook, then that's going to be very hard for someone who's on the losing end of that to dig their way out. That's the thing we can see over and over again from other industries that have had high level of information transparency on the internet. It's really hard to then try to go and dig yourself out of that once it's already out there. But once it's out there, the winners, they get even richer, and the poor get even poorer. And it can tend to become more of a winner-take-all type of situation if you're in a competitive market, and people are really paying attention to these ratings. It can really start to hurt you. So we'll see, but I love that question because it kind of brings it back up to a real strategic level. This is talking about the whole farm. This is not just talking about the barn or about the house. It's about the whole farm.
Right,
the reputational stuff really does impact things at that level, versus it just being 1 year of reimbursement that we're talking about here.
All right. Well, on that note, we actually are out of time. We will obviously be back again in September with another event. Tom, as always, thank you so much. And to remind our audience, a lot of questions we didn't get to, you can email Tom directly at tom@saignite.com. And we'll see you next month.
Thanks, Carol.
Bye.
Bye-bye, all.